Hello, everybody, in person and online. Thank you for being here for Department of Medicine Grand Rounds today. Please leave any comments or questions in the chat if you're on Zoom, and we'll get to those at the end. Today, I'd like to welcome Dr. Daniel Kim. He is a non-invasive cardiologist and assistant professor in the Division of Cardiology at the University of Washington. Clinically, he sees patients with a focus on preventative cardiology and exercise physiology, and separately attends at the UW-Montlake campus. Dr. Kim received his medical degree from the University of Michigan, graduating with distinction in research and a member of the Alpha Omega Alpha Honor Society. He also received a PhD in genome sciences and the MPH in biostatistics from the University of Washington. He completed his clinical training in internal medicine and cardiovascular medicine as a member of the physician scientist training pathway at Stanford University. He also served as a lead fellow for the Translational Investigator Program at Stanford University while in training. Dr. Kim's research focuses on integration of artificial intelligence and statistical methods to improve physical activity as an avenue to prevent cardiometabolic disease. His work has been funded by the NIH, American Heart Association, American Diabetes Association, the Smirnoff Cardiovascular Research Foundation, and the Robert Wynn Excellence in Clinical Trials Foundation. Please welcome Dr. Dan Kim.
All right, thank you for that introduction. This is my disclosure slide, so nothing significant to disclose. And here's an outline of what we'll be going through. And so just focusing first on the introductions and motivations for my research. So when I was taking this talk on the road and talking to different universities about my background and how I became what I am, I imagined it being a nice linear pathway where I just go through training and I end up an attending or, physician scientist. But the reality is it's a very long, winding road with lots of loops, and it's not necessarily about it's about the journey and the people we meet along the way that mentor you and help you throughout all these things. But I just want to focus on one event that really shaped me as a preventive cardiologist. And this was in June 2020, so the throes of COVID. At that time, I got a call from my mom, who was here in Seattle, about my dad, who was in Korea. And she said, "Oh, your dad had a heart attack and he was rushed over to the cath lab and got a stent, and he seems to be doing okay." Remind you, this is like the height of COVID. There was a 2-week quarantine in Korea, so there's no way for any of us, including my mom even, to go and visit him. And my dad's actually the ideal patient in that he had his risk factors identified in his 40s and 50s, and then he really took exercise seriously, reversed all of his risk factors, came off all his meds, and in his early 60s was at an ideal BMI. So, modern medicine, a total win in that sense. And as I started to look at this, and this is my dad holding me back and then my dad holding my son, so his grandson, you start to see how these things are cyclical and that a lot of this is genetically determined, and that if you want to prevent the disease in yourself, so for me, then I need to start exercising and taking things more seriously for myself to prevent myself from having heart disease moving forward. So that's really shaped my clinical training and practice. And so for the last 4 or so years, I had the great pleasure of being Ewan Ashley's clinic fellow. And if you don't know Ewan, he's now the chair of medicine at Stanford. And he's kind of like the godfather of precision medicine, or at least he likes to think so. And this is a picture of him with President Obama when he was honored for that role in precision medicine. And so in his clinic, what I learned is that all data really helps us to deliver more precise treatments, diagnostics, et cetera, to the patients. So with that in mind, I'm just going to focus today's talk on digital health and artificial intelligence. So as a preface, what is digital health? I will primarily be talking about wearables, smartphone apps, but it encompasses things like telemedicine, remote monitoring, and also virtual cardiac rehabilitation. And if the x-axis here is the lifespan of the individual, the y-axis is the health span. That is, how healthy are they? And we're really good in modern medicine during the acute hospitalization, the post-acute, and the remission phases, hopefully. But we're really bad at the prevention aspect of things. So when I came here, I met with Eugene Yang and Shwetak Patel, who's in computer science, and we were thinking about how can we do better prevention using digital health and AI. And so the idea was that we can take all this different data. And what AI does really well is it parses out the noise and gets you a signal. And we use that as an integration engine for all the stuff, all the different data that we have. And from there, hopefully we can get to eventually improve patient outcomes. And today I'll focus mostly on the digital and wearable data, sociodemographics, and traditional biomarkers. But the goal is earlier detection and prevention, and hopefully improving patient outcomes. So the vehicle of my work in digital health has been My Heart Count. So I'll just introduce this in the next section. So My Heart Counts is a smartphone application, and it was the brainchild of my mentor, Ewan, back in 2015 or so. So it was developed in collaboration with Apple, and later on there was a collaboration with Google, and it was the fastest recruited medical study of its time, recruiting 40,000 patients in 3 weeks, and it has over 100,000 users to date. And we got really nice, passive, dense, granular data on smartphone accelerometry, wearable data, etc. And this is just giving you like an idea of the different activity patterns that we're able to pick up just through this app alone. It also collected 9 million sleep periods, a bunch of workouts, numerous surveys and self-reported clinical data, and later it was updated to include a HIPAA-compliant link to Epic and also 23andMe genetic data. So the research with My Heart Counts, first focusing on the observational and epidemiologic studies, this was sort of the landmark first paper. And what it showed is that we could use just the smartphone sensors in the smartphone itself. This was before wearables in 2016, and recapitulate a lot of foundational epidemiologic studies for cardiovascular disease. So what we're showing in this middle graph is that those who are inactive have more symptoms of chest pain, diabetes, heart disease, joint pain, etc. And all these different clustering of individuals, again, that we did with just a smartphone accelerometer, strongly associated with cardiovascular disease symptoms and quality of life. More recently, we used this app and we gave 120 healthcare workers in the UK an Apple Watch, and then they did symptom surveys, and then they also just wore the watch. And what we found is that the people who had long COVID, shown here in dark blue, as compared to those who recovered very rapidly in light blue, had distinct wearable patterns that we could detect just by using the smartwatch. Getting into the next aspect of My Heart Counts is the fully digital trials. So this was actually the very first fully digital trial. And after 1 week of observation in our base study, they were invited to enroll in a randomized crossover trial where we tested 4 different digital nudges. So all of these digitally delivered prompts increase short-term activity, which is kind of weird because you wouldn't expect something like a prompt to read the AHA website to increase your step count significantly. So that's where I came in that I was invited a couple years later to reanalyze the data. And what's nice about smartphone trials and digital health in general is that they allow for continued passive enrollment without a study coordinator, totally automated with full digital consent and trial processes. So as long as the app is active, you can continue that trial indefinitely. So that allowed us to get about a 3x increase in power and increased signal discernment. And what we found is when we reanalyze the data in the future, even when excluding the old data, the personalized coaching nudges shown here in red as compared to blue in the prior study, it had better precision and it was statistically significant and clinically significant in how much more it increased the step count as compared to the other prompts. And this is showing it another way with Tukey's clustering patterns. And what we think about the hourly stand prompt is that probably getting the prompt every hour, so up to 12 times a day, is more helpful than just getting one prompt once a day. And that's why it's improved as compared to the daily 10,000 step reminder and the read the AHA guidelines. The last aspect of My Heart Counts is the open data sharing, which remains important today. So all the data that we generated in the initial release was shared with the scientific community, and it sadly remains one of the largest data set collections of wearables, smartphone accelerometry data, and linked health outcomes. This is actually from a very recent publication that I'll dive into later, but this is our conference proceedings for the NeurIPS conference. And what we're showing here at the bottom is that the My Heart Counts data set is the largest with over 60 million hours of data collected over 10 years with all sorts of different modalities, and all of it is open access as compared to things like the Google Fitbit and Apple Health Trial. So this is a big table, but the idea is that we had a 3x increase in users from when we previously released the data, and that we also had average number of records, that is how many things that they contributed, about 23x. And all of this stuff is novel, stuff related to COVID, stuff related to mindset, and vaping and cigarette smoking. But we wanted to focus just on one thing that we could immediately release, and that was the 6-minute walk test. So what we showed here in this publication was that we released 30,000 6-minute walks, which was about, on release, 10x the biggest number of 6-minute walks ever publicly released. And they showed the expected epidemiologic associations with age, BMI, and cardiovascular disease status. So here on the left, those with the younger ages shown in blue as compared to those with the oldest ages shown in red. This is their heart rate trend over the 6-minute walk test. Here we have BMI, so those with the highest BMI shown in red as compared to those with the lowest in blue. Those with higher BMI had lower 6-minute walk distance. And then things like pulmonary arterial hypertension, as expected, those folks who are very sick had lower 6-minute walk distance. And we also found, interestingly, but not in a controlled setting, that use of the app was associated with a 20-meter change in your 6-minute walk distance when it was separated by at least 1 week. And along with that ethos of open source data, we also wanted to create an equation that could be used by clinicians and also by patients. So we've developed these reference equations for all patients and those with cardiovascular disease that's currently in review at JMIR. And with the open data aspect, we also have updated the website to include the data release for the 6-minute walk, but also for our equations, all of our code, etc. So that's a summary of my heart counts, basically overlapping a little bit with when I stepped in about 2021. Let's talk about some of their limitations. Number one is that there is pretty poor diversity in our participants. So number one, it was iPhone only, at least on the initial launch. And the recruitment was local to Silicon Valley. So the population that we got, which was 70% male, middle-aged, almost 90% white or Asian, and 40% with a master's degree or higher, is definitely not generalizable to the population. And this gets at the idea of digital health equity in a paper that I wrote with one of my mentors, Fatima Rodriguez. If you imagine an inverse pyramid where the individual is at the bottom, all of these different elements at the top feed down to every element below it, and it affects the individual. And there's lots of modifying social determinants of health, and those specifically at the individual level are things like race and ethnicity, limited English, and gender. And we're not really accounting for that as in our last app. And there's lots of things we can do to try and improve this, which I'll get into in a little bit. The last aspect, limitation of My Heart Counts as it was originally made, is that it required the personalized prompts that are significantly improving your step count, required experts to sit down and craft 7 different digital interventions for each of the baseline activity group clusters. So because they had to come together and come to consensus, it really limits the scalability of that type of work. So along those lines, one of the things, this was back in 2022, so when LLMs were still just in their nascency, that we thought is that we could use AI and LLMs to increase autonomous trial conduct. And we wrote a editorial in circulation about this. And the idea is that we have the large language model that lives in the app. It sends out the text message, and then it learns from its successes and also its failures. So it learns what exactly each individual needs in order to be motivated to exercise. And although this is a small change at the individual level, like plus 500 steps or so, or adding 5 minutes of exercise to your day, that can account for a huge change at the population level. So conclusions from this section, My Heart Counts was and is a widely used smartphone app. All the data is publicly shared. It was the first digital trial that showed personalization improves outcomes and that we need future work. So moving on to the next section, large language models of scalable coaches. This is going into the behavioral health aspect. This is an outline of the work that's been funded by the ADA, but we wanted to make a new smartphone app by integrating the AI into the app to allow for autonomous trials and then conduct short and long-term trials. So I'm going to focus first on this AI integration, which was generously funded by the Center for Digital Health at Stanford. But the goal here was we want to pre-train a language model to provide expert coaching prompts that are grounded in behavioral psychology. So specifically, we want to use the stage of change model. And those of you, who have done med school recently, you probably remember that this is the model used to assess users or an individual's readiness to change their behavior. So most commonly in smoking cessation. Are they pre-contemplative? That is, they're not even thinking of quitting smoking. Or are they in the action phase where they're starting to take concrete steps to quit smoking? Or are they in the maintenance phase where they've quit smoking for X number of months, they're trying to stay away from smoking? This also works very well for physical activity. And what the literature shows is if you match the prompt to an individual stage of change, it increases efficacy. And as people evolve through their stage of change, their coaching prompts change as well. And this reinforces long-term behavioral change. So we took Llama, which is an open source LLM, and we fine-tuned it to create Llama Health Coach. And then from there, we gave it a prompt, and then it gave us an output, and then we conducted a survey. And we sent this out to 632 prior My Heart Counts participants who are open to research-related contact. And it was basically a forced choice A/B survey where they were asked to choose between an LM-generated prompt or a human coach expert-generated prompt. And so we would have been okay with equivalency, which is to say the LM is just as good, if not just as good within a range of error as the human coach, because this allows us to scale up significantly. What we actually found, though, is that across all the different stages of change, the LLM was preferred strongly to the human coach. And what this gets at is, I think, one of the underlying points of LLMs, which is they're always on their best behavior. They're always very enthusiastic and chipper, bright and bushy-tailed. And it seems that people like that quite a bit more when it comes to motivating them to do physical activity. So what this suggested to us is that we could use LLM-generated coaching prompts as a way to scale up our delivery of autonomous behavioral trials. So from there, we had the pre-trained language model, and we have the app, and so we wanted to integrate it into our next smartphone app iteration. And from there, because it's autonomous, because it has all the data it needs, we can do trials, fully digital trials, in just about any condition that we want to. So heart failure, Spanish-speaking adults, and type 2 diabetes being ones that we're thinking about immediately off the top of our heads. So I'll focus a little bit on the Spanish-speaking adults project. And this is getting back to that idea of digital health equity. And so with this project, what we're trying to do is do community co-design. That is, we reach out to the patients that we're trying to help increase their physical activity and ask, what do you need in your smartphone app to make it more effective for you? And then by providing Spanish fluent translations, we want to focus on digital inclusion, which is trying to bring in people who are going to benefit the most from our app and our interventions. And this is important because in work that we showed in JACC Advances, about half of all digital health trials purposely exclude people who don't speak English. So non-English fluency was an exclusion criteria in about 13%. And then in other ways, they also said that you have to be fluent in English, and that's a strict inclusion criteria. And if you combine those, you get over 50% of these digital health trials just specifically excluding people who don't meet their criteria. So along those lines, we wanted to develop a parallel version of our app to increase the digital health inclusion of Latinx populations. So here we wanted to repeat what we've done before, but also do some language training and pre-train a language model to be Spanish fluent. And what we did and what we found is that although not quite as dramatic, and we definitely didn't have quite as many participants in different groups, we did show a general trend towards people preferring the MHC coach, that is our fine-tuned language model specific for Spanish. And so now what we're doing is we're rolling out this short-term trial, randomized crossover trial, where they either get a generic prompt, which is to reach 10,000 steps, or they get the fine-tuned language model prompt, and then they cross over into the other arm. So conclusions from this section is that personalization leads to improvements in physical activity. Hopefully we've hit that quite a bit. And that language models offer us a way to significantly scale up potential decentralized trials in the immediate future, and that we also need to focus on digital inclusion as we move forward to ensure that the patients that we study are generalizable and representative of the populations we actually want to reach. So in the final section, I'm going to talk about the new My Heart Count app and how it's a digital health platform, and then introduce a couple of different projects that are in their nascency. So just to put it out there, we've released our new app. We did our media thing yesterday, and so it's now available to download. And there will be a QR code at the end if you're interested. But these are the main features of the app, and we're going to go through all of them except for the increasing digital inclusion aspect because I think I hit that pretty hard over in the last section. So first, the autonomous digital trials. Why is it important to have autonomous digital trials? Number one is that it allows patients to be basically in their own homes. So it increases the accessibility. They don't need to drive or commute all the way over to Seattle if they live in Eastern Washington or Alaska or whatever to participate in our trial. And what that allows us to do is really broaden the participant reach. So anywhere in the country is our current IRB in the US. And so we could reach anyone wherever they are in their own homes. And then by designing the technical aspects, which I'll talk about later, we get really dense and great data from it. Going into the AI and behavioral science integration aspect, this gets at the long-term trial that we're currently not launching, and we're working on some of the stuff under the hood. But the idea of this long-term trial is we want to enable long-term behavior change. I've talked a lot about short-term, one-week differences, but we know that's not going to put a dent in our cardiovascular disease risk. It's the long-term behavior change that matters. So we want to integrate the stage of change, which I've talked about, but also chatbot coaches. And we want to measure directly, clinically meaningful phenotypes. So change in weight, A1C, and then, of course, the daily steps, which we've studied quite in depth up to now. So there's lots of different coach personalities. And so just an example, I might like analytic Amy, who focuses on raw data and gives you numbers that says you need to up your game because your steps are down by 7%. Whereas someone like, say, my wife, when she went through this, she wanted motivational Maria because motivational Maria is more positive and helpful in her mindset. So you'll receive the daily stage of change match prompt in the chosen coach's voice and tone. And you can also chat with the coach as a form of social accountability. That is, the coach will notice when you're not adhering to your normal routines and rhythms and act as that sort of account buddy or gym buddy that helps you keep on the straight and narrow with regards to your physical activity. So here we're not going to do a crossover design. It's just a one-to-one randomization. And then there will be the daily behavioral interventions and chatbot, or just a daily 10,000 step reminder. And then we're going to collect changes in mean daily steps, change in weight, and A1C via the EHR link. And I want to talk just briefly about the stuff that's going on under the hood and at a very high level. So I showed you like a very simplified diagram of how the reinforcement learning works. It is quite grossly oversimplified in the sense that there's a lot of stuff that actually is going to be included. So the reinforcement learning will be quite difficult. The digital twin aspect is also something under the hood. And I just want to focus on something called just-in-time adaptive interventions. So here, the idea is that the prompt is good, sure, but whether the prompt is acted on depends on if the person is in the right time and place. That is, if you send me a prompt at 9 a.m. when I'm in a meeting or I'm just dropping off my kid at daycare, I'm not going to respond to that prompt. I'm not even going to look at it. But if you send it to me at 3 p.m. when I'm kind of, done with my afternoon meetings and winding down my day, that's more likely to be effective for me. So it has certain specific variables, like maybe this person wants to get their prompts around lunchtime. And then if certain conditions are met and it's the right time and place to send the prompt, then we send it to the individual. But if it's not, then it waits and it finds a better time to deliver it to the individual. So we're trying to optimize the time and place as well as the prompt itself to make sure that it gets to the individual when they're in the right time and headspace to respond to it. The other aspect of My Heart Counts that the new app that's pretty interesting is the patient-facing dashboard. So here you have a tab called Heart Health, And you have all this, you have a cumulative score, and then you have individual components. So we have 9 individual components, and they're based, and then you can click on each one and go into detail on, say, your sleep, your steps, your diet, etc. And it's based off of the AHA's Life's Essential 8, but we were told if we wanted to add something like mental health to there, that we'd need to go and argue with the AHA to get it. So we're doing our own thing here. And so it integrates all the wearable data, EHR data, surveys, et cetera, and it gives people real-time feedback on how their individual cardiovascular risk factors influence their overall heart health, which is to say, sometimes when you tell a patient they have hypertension or hyperlipidemia, they don't know how to respond to that because they feel fine. They're just abstract numbers. So by showing them how those numbers influence their cardiovascular health early, we're hoping that it can help influence behavior in the long term. The next aspect of My Heart Counts that is pretty interesting is the open source and modular platform aspect to it, which allows us to use it as a digital health platform. So this is work that's been really led by Paul Schmiedmeyer, who's an instructor at Stanford. But we really care about the open science and open source aspect, and we want to make the world a better place. And along those lines, everything that we've created has been open source. And from there, we can incorporate new wearables and sensors, which I'll talk about in a little bit. We can add in disease-specific modules. That is, if someone listening here wants to do migraines and AFib, for example, we can easily add that in. And we can also change up behavioral intervention because the underlying LLM engine just needs a different prompt. And all this leads to what we hope is an acceleration in digital health research. As a sidebar, there used to be something called FDA My Studies, which was something similar to this, but that shut down actually recently when that person left the FDA. The last aspect of the new My Heart Counts app that I want to talk about is the comprehensive digital data bank. This is an overview of the timeline of our trial, of our study, I should say, in that you download the app, you do your enrollment, and then days 1 to 7, it's basically just getting a sense of what you do on a daily basis. Then you enroll in the short-term physical trial for 2 weeks. And then from week 3 onward, it's really just long-term observational follow-up. And I'm not going to go through all these different surveys and tasks that we ask people to do, but what I'm trying to point out is we get a ton of data from the surveys, and then we're also getting all this passive data collection, and then we're also getting external data linkage through the EHR link. And this is diving into that NeurIPS conference paper that we have. And this is the old data, not the new one, but I just want to point out just how dense the data is. We have, what does that say? 2.82 million participant days, 67 million hours of data. And from there, what they've actually been able to do, which is quite interesting, is impute someone's behavior. That is, like, figure out what a person should be doing based on their baseline. And it's able to do it in quite an accurate fashion. And then, oh, interesting. And in along those lines with the open source sort of mindset that we have, we've launched a website on our My Heart Counts page that tracks all the different the data release, the code, and the data set, but you can also submit your own models to try and forecast users' behavior. So that's a summary of what we've done so far. I want to take this last bit of time to talk about what we're working on next. So a little bit of divergence going into a project we've named CAR-T Sentinel. This idea is for outpatient monitoring of cytokine release storm. And this is a grant that we have in review with CRI with Emily Liang, who's actually my co-resident back in the day, and Mohammed Saror. But the reason why this is important is CAR-T therapy requires patients currently to come and be hospitalized in the hospital for anywhere between 1 to 3 weeks or so. And so they have to leave their homes, whether they're in rural Wyoming, and come all the way to Seattle. And then they accrue quite a hospital bill. And the data that we get is really sparse. It's really just the Q4-hour vitals that we're getting, and then along with daily labs, if that. So what we proposed is to use the My Heart Counts app and give people a wearable and then get continuous wearable data on heart rate, temperature, SpO2, and then from there, really just focus on the early CRS or cytokine release storm prediction. And our hope is if we can implement this, then we can improve access and equity for CAR T therapy to be accessible to people in their homes wherever they are. And this is for certain subtypes, I should say, that would be treated with CAR T. Of course, we're not going to take like the very high risk people and let them do it outpatient. Another project that is in the works is with some co-Is, including Fatima and Chris. But the idea here is we want to do a better job of preventive cardiology in diabetics. So as we probably all know, 11% of the population is affected by type 2 diabetes, and that number is just going up. And there's this target goal called the ABCs, the A being A1C, the B being blood pressure, the C being cholesterol. And when we meet this, then it turns out that diabetics live a lot longer. They don't get heart disease because it's the number one killer in diabetics. But only about 1 in 5 patients actually reaches this goal. And there's a huge mismatch between what patients need and what we can actually provide. So here we're proposing to use my heart counts and integrate it with CGM sensors. We already have the blood pressure cuff integration through Chris's trial or study. And from there, focus on those ABCs, the A1C, the blood pressure targets, and the LDL, and generate physician summaries or provider summaries that we can send to their PCPs, their endocrinologists, their cardiologists, et cetera, and report, hey, your patient was out of range for their glucose, 70% of the time, or hey, they're not reaching their step count goal and their LDL is still 120. We need to work on that. And from there, doing a multi-center trial where we incorporate all the different digital health interventions versus just a CGM that they would get because they're type 2 diabetic. And we see what is the difference that we can achieve on ABC attainment rate. And I want to point out that the app was generously recently funded by the Locke Charitable Trust. And the goal here is that if we can prove this in a trial for efficacy, then we can start to think about things like CORI or implementation science. Can we generalize it to the broader hospital and community? And that's where Chris's expertise really comes in helping us to bring in rural folks. And then Fatima's expertise in bringing in Latinx populations is also going to be of key importance there. The final aspect of what's next that I'll present is on wearable-derived digital phenotyping for HCM. So for this, I wanted to put the Nick Fury meme of I'm assembling a team, but I've kind of assembled an Avengers team of HCM specialists. So Fareed, who's here at UW, Ahmed Masri at OHSU, Matt Wheeler at Stanford. And the idea is we want to create a digital phenotype for HCM that we can use to track disease progress and also response to treatment. So here again, My Heart Counts, the app is the underlying linchpin, but with the dense amount of data that we get retrospectively, we just want to recruit people who are diagnosed with HCM and then look at all their retrospective wearable data and see if we can create an algorithm that predicts when they should be diagnosed with HCM. And then from there, once we have that algorithm, we want to apply it forward as a prospective study and then just track how these individuals do and see can the algorithm pick up in real time when a patient starts to develop symptoms from obstructive HCM. And we're going to correlate that with RNA-seq samples that will be taken at different time points. And then finally, we want to see how we can track the digital phenotype over time because we have wonderful cardiac myosin inhibitors that reverse the symptoms of HCM with obstruction. And we want to see how we can track that with the digital phenotype. So the final slide of what's next is that I'm very open to collaboration. So for anyone on the call watching here, if you're interested in smartphone-based AI, machine learning, research in healthcare, we can probably do it in any disease, any patient population. And if you're interested in behavioral interventions that are text-based, we can probably do that as well. So coming full circle, my dad was my impetus for going into preventive cardiology. Because I wanted to prevent things like that happening to people like my dad, but also in myself, frankly. And now that I have my own kid, this is me with my 1-day-old at the time son in a similar position as my dad. My academic, personal, and life goal is to try and make the world a better place sometime before I leave this mortal coil. So along those lines, this is sort of the focus of the next 5 years of my academic life. But I want to emphasize as the leaving points is that we have a lot of cynicism nowadays about technology, but I think that in academic hands, in the certain hands, technology can still be a force for good. We have a lot of data. We can leverage that to make our patients' lives better. And that by using this data that is often overwhelming to us as clinicians, we can more precisely prevent, diagnose, and treat cardiovascular disease. And that finally, the work that we do is trying to help people to live healthier and longer lives wherever they live in the United States and beyond. So I just want to thank the village of mentors that I have. I've talked about, I think, all of them in detail except for Kelly. And then some of my former mentors, and I'll just point out Gail, who's still here as division head in medical genetics. And then I want to remember Debbie Nickerson, who, in very blunt terms, took me under her arm, under her wing in 2011, and has really helped mold me into the physician and scientist I am today. And we miss her very much. And just show my obligatory lab pictures, and then ask if there's any questions. So let me check if there's online any questions. No questions online?
I'll start with it.
Uh-huh.
So, I'm interested in CAR T cell therapy, cytokine release syndrome, et cetera. You take me back there because I really didn't understand the specifics of what was involved with that app and monitoring. So,
Yep. These are very dumbed down slides.
yeah, I just wondered if I could, I mean, I imagine that you're getting some values that are you just looking at vitals basically in a continuous fashion?
Essentially, yes. So what's nice is that presently the Apple Watch, as you know, detects heart rate, detects your SpO2, detects your temperature. And because of that, we're wondering, is it a cost-effective way to just use the Apple Watch that we get through the Apple Investigator program? And then can we use that and the underlying infrastructure of My Heart Counts to just create an app that detects their different physiologic variables and then sends alerts to the patient if they need to go connect with their doctor. And the hope is to identify CRS early because there's lots of small changes that occur, probably an increase in heart rate before anything else, that reflect that underlying distributive physiology that we see with CRS.
Yeah, I was just, you said, because I was saying, how are you going to monitor, for early detection? And you have biomarkers, et cetera. So that's not really the point.
Yeah, the point is
the point is just using simple sort of physiologic measurement.
Correct. And the biomarkers are more for the discovery aspect of things, which I threw in there to try and increase the breadth of the grant. Yep. Other questions?
I have a quick question about the notifications for the behavioral interventions that you're talking about, and kind of like the different times of the day. Is that something that you can change, or you can tell the app like, hey, on this, like you can change it daily, or be like on Wednesdays, this is when I want to be notified?
Yep. You can't get into specific scheduling, but you can choose your time of day. So at first it was all 9 a.m., which was really annoying to me. So I asked them to implement it, and now I choose 4 p.m.
Okay,
every day.
every day.
There's a QR code.
Use it. Say like, remind me again in an hour.
You can't,
You can. Okay.
but we do log if you actually open the app and look at the alert.
Okay.
Because if you do engage with it, then that helps us to figure out if the intervention was successful. Because it might just be on your home screen, then you swipe it away.
I mean, there's a question in the chat that I will actually, are you able to see the chat?
I am not.
Oh, I can ask a question, but if you don't mind repeating the question.
Yes.
They can hear it. Let's see. What is the MCH age range that would benefit patients? Is it ever too late to employ this? Sorry, there's a lot of questions. Or are you studying this? For example, suppose the patient is 65 and has a long life of high cholesterol, but is pre-heart attack.
Yeah, great question. So the MHC app is designed for anyone who's 18 plus. We want to avoid the pediatric population because the IRB regulations is quite strict in that setting. As far as like, is it too late to start anyone? No, it's never too late to start and get more active. The more active you are earlier in life, that certainly helps you retain your vigor as you age. And then we are specifically studying elder Hispanic Latinx patients through an NIA grant that Dara helped to set up in the audience there. So we are looking at the elderly population, but we shift focus a little bit instead of just step counts to also step counts plus resistance training. Like we want to prevent a fall, balance PT, etc.
Next question. How did you learn to manage massive amounts of data such as this? Curious what parts of our winding journey allowed you to develop these skills for other people who are interested in being able to get involved in research such as this?
Yeah, great. So the question from Austin is how did you learn to manage massive amounts of data, and what sort of skills you got to help you with the research? So unfortunately, that's more of like a circumstance type thing. So my PhD was in genome sciences, so it was basically bioinformatics, and I got a MPH in biostatistics, so also a lot of coding, bioinformatics type stuff. Frankly, you can use Claude Code with Pro, I think 5 hours a day or something, and it does help you to learn the basics of how to do coding and figure out how to do Python scripts to manage these large amounts of data. And then as the question, has the app increased my own amount of exercise? Yes, but I'm also trying to game the results a little bit by being active when I get the personalized notifications. What I will say is during the long-term phase, we've now opened up the app. Before we were focusing on steps, running, jogging, whatever you choose. But after the trial period is done, then whatever activity you select or whatever activity that you're generally doing, whether that's yoga or for me, cycling, that's what it's going to recommend that you do. And so it's actually been more helpful to me in the post-trial aspect of things. Let's see.
Additional question, is there a trial that you're going to conduct or thinking to conduct that would be MHC versus no MHC and then long-term cardiovascular complications? Because that's really, I think, the goal. And
Yep.
so that's going to be a long study, probably like 10 or 15 years of follow-up.
Yep. So the question was, do we plan on doing a future study of MHC/digital health interventions in general versus nothing and see what the long-term outcomes are? I hadn't actually thought about it. We kind of peripherally touch on it in the idea of the diabetes grant, if I go back to it.
It would be sort of like a long-term, almost like Framingham cohort study.
Yep.
Or, like Brigham versus study or something like that. Sort of what I was thinking of, large population.
And so I think because
see what the long-term outcomes are.
the problem with preventive trials is that the N is very massive to power the very small amount of events. So the hope was by focusing on diabetics and focusing on the ABC attainment that we can kind of do that sort of thing in that our digital health intervention that we're using is the MHC app, which integrates all the different data streams into one versus just giving them a CGM, connecting it to their Abbott or what have you provider, and then having them use that app on their own. So it's like a digital health to digital health, but kind of an MHC versus nothing type thing. Other questions? Yep, in the back.
Things to use, like menstrual tracking apps or like health tracking apps in general is data privacy and the way that our health data can be used against us potentially by either like volatile political administrations or insurance companies. So can you talk a little bit about how privacy is maintained?
Yeah, so the question was about data privacy and that younger generations, I think everyone, frankly, is a little afraid about what happens with their data. So the things we do to try and prevent that, number one is that this is all run through like university IT at incredibly expensive rates. That is all HIPAA compliant and it's all held like off server. And a lot of the data is not in a processable format. It's stored in Parquet files, as we say, and it's stored on like terabytes and terabytes of data are stored just on like hard drives that are backed up. So a lot of it is not accessible in the cloud, number one. Number two is the AI aspect. And that's a real big one. And what we've done there is we use what's called sovereign AI, which is say it's not a learning instance of AI. We're not giving it to ChatGPT and asking ChatGPT to process and learn off of your data. All the data is there in an instanced version of GPT that's not learning, doesn't feed back to them whatsoever. Does that answer your question? Yeah, we try to mitigate it as best we can. Yes, that's all I'll say there.
May have kind of partially answered this question in the chat. Can you talk about how NHC is linked to Epic and what it took to achieve this? I'm curious about how security.
Yeah, so that is actually a one-way. So the question was, how is the app integrated with Epic? So at present, this research is for the future, the one that's on the slide right now. But at present, it's a one-way Epic link. So that is, people can choose to share their Epic records with us, and then that's stored securely, as was talked about before. The two-way communication, I think, has some difficulties in that anything you give to Epic, they will basically take from you. And so there's ways that we can get around this, like secure emails, maybe just doing a messaging inbox message versus sharing the data, that sort of thing. But that's something I'm working on thinking about with the bioinformatics folks. Other questions?
I was curious, have you started collecting other kind of lipid markers like Lp(a)?
If it's collected by the EHR, then we certainly see it. Yes, yes. So Lp(a) is definitely of interest for us. Yeah.
And then I'm also curious, it seems like you've collected a ton of data so far. But in your analysis, is there anything specific or any specific outcome that you particularly found maybe like surprising or really maybe just really exciting?
Maybe not exciting, but surprising. So the question is, have I found some stuff in my analysis that's surprising? And I think the big one has been recapitulation that mental health has a big impact on cardiovascular outcomes. So if people are depressed or anxious, then they have way more cardiovascular symptoms and also a higher mortality rate, which was recapitulated in this data. And that's something that was a big impetus for me. I mentioned Life's Essential 8 and how we wanted to implement something like it, but we couldn't get the AHA to license it because we wanted to add mental health in. And so we just made our own offshoot. Mental health is crucially important for cardiovascular health. And so that's something that was very surprising to me, but also something we wanted to emphasize for the patients and participants that use our app.
I apologize if I missed this, but how do you collect the data on mental health? Is it like the PHQ-9 that they fill out?
So not a PHQ-9, we use the WHO-5, which is a more generalized mental health survey. It doesn't address the suicidality aspect because when we were trying to get that through IRB, if they answer positive on the suicidality aspect, someone needs to act on it. And because this is all fully autonomous, the IRB didn't want that. Same with the GAD-7. Actually, we do have the GAD-7. Let me take that back. Other questions?
Are you seeing like any issues while using LLM with like context management? Like when like you use with AI, like when you ask like a question, you need to like provide like direct information.
Oh, I mean, like you're talking about like giving all the information in the prompt itself to help the LLM.
Yeah, like I guess like the issue with AI models is like if you provide something differently, it gives like a different answer.
Yeah. So the way we get around that is that's the way we're using the LLM, at least right now, is very simple, which is to say that we ask it to generate a behavioral prompt based on the parameters that, we give. And we give the stage of change, and this is the pre-trained model. And then we also add in the age, gender, what their favorite activities are, that sort of thing. And so we're not asking it to do anything fancy at this stage. In the future, that will be something that we need to think about with a sovereign instance of whatever we end up using, which is cheapest. Other questions?
Got some comments in the chat. Thanks, just signed up for MRC. I just downloaded it.
Thank you, guys. All right, thank you.